All right. So good morning, good afternoon to everybody. Welcome to the webinar on using cash and voucher assistance for nutrition outcomes. This webinar is meant to be a first glimpse into the work of the Global Nutrition Cluster on this topic and my engagement over the last 3 years on identifying opportunities and limitations for the use of cash and voucher assistance to achieve nutrition outcomes. My name is Andre Dur. I am seconded by CashCap, which is part of the NRC NORCAP roster, to the Global Nutrition Cluster, and I started my assignment at the end of August, specifically to help the Global Nutrition Cluster to consolidate evidence and to develop guidance on the use of cash and vouchers for nutrition. I can see I have 30 participants now. I hope that most of you are nutritionists because that is my target audience. But if some cash specialists are around the table, or maybe from some other actors, from some other sectors, that would also be appreciated. And I also hope that we have some colleagues from the nutrition cluster coordination teams on the ground, because one of the reasons I'm doing this webinar now is also because I wanted to give a first glimpse in my work. I know that there's a lot of questions around the topic, and I wanted to make sure that it happens this year so that I can maybe give some inspiration for the planning of response in the different contexts for next year. This presentation will last approximately 30 to 35 minutes, and then we'll still have some time to discuss, to raise questions, to make suggestions. Great. Okay. So very briefly, and the objective of today is really to look at some of the potential and some of the limitations of using cash and voucher assistance in nutrition programming, to present some of the evidence and also the practice to the extent that I'm able to do that at this stage. To talk about the GNC's engagement and the next step in this project. These are the main objectives. Just a disclaimer from the beginning, I do not have all the answers. I started 3 months ago. I'm still learning. I'm not a nutritionist, so I won't have all the answers. Actually, I will have some questions as well. So this is just for you to understand that if I ask questions and I don't give an answer, the question is more maybe geared towards you. Then in terms of what we're going to talk about today, so I'll start with cash and voucher assistance terminology, because I believe that most of you are nutritionists and maybe not very familiar with the terminology. I'll talk about some of the frameworks, including the framework on malnutrition, as well as a new one that I'm developing on supply and demand side barriers to nutrition security. I will talk about cash and voucher assistance components in the nutrition response. So how can we integrate cash and vouchers in a response? What can we maybe complement? What can we potentially substitute? Yeah. Talk about some additional considerations when it comes to the design and other aspects, and about the GNC's engagement and next steps. So starting off with the terminology, and we'll in the first step talk about modalities, assistance modalities. So essentially there is, very simply speaking, 4 different ways to transfer humanitarian assistance. One is in kind, one is cash, one is vouchers, and one is services. Services here has the cross. So for nutrition outcomes, of course, health services are the most relevant ones. But of course, it can also relate to other kinds of services. Cash, definition of cash is essentially the provision of money to individuals, households, or communities to address their needs. Yeah? Cash is, as you will see later, can be given in different ways, but usually it's given in a way that people have liberty to spend it the way they think is best. Somebody cannot hear. I could just read the message. The rest of you can still hear me?
Yes.
Okay, great. So I'll continue. Good. Vouchers, on the other hand, they're also a market-based modality. But with vouchers are usually delivered either electronically or in the form of a piece of paper, and they give access to either goods or services in specific shops or with specific vendors. And also in terms of choice, vouchers don't provide the same level of choice. It really depends on what the implementing organization defines what people can obtain with these vouchers. And then people can only go to contracted vendors to obtain goods and services. So it's a more limited way of transferring cash and voucher assistance. I think in kind, I don't have to explain. Services is clear as well. Please remember the symbols because we'll get back to them. Of course, these modalities can be given, as one or in combination. So there's multiple combinations possible in terms of providing these and combining these types of modalities. Now I'm using some of the CALP material here. First distinction that we need to make is between sector-specific and basic needs. Yeah? Sector-specific would, for example, be much of what the nutrition response entails. All shelter-related, for example, interventions, water and sanitation-related interventions with specific sector objectives. Basic needs is more kind of what people require on a daily basis to survive and to address their kind of to address their living conditions comprehensively. And for that, we often use the term multi-purpose cash transfers. Yeah, so that's an important distinction because with multi-purpose cash, you try to address basic needs, but of course you don't attempt and you cannot actually address some of the more sector-specific needs that require a different approach. Then, in terms of qualifying conditions, we make the distinction between conditional and unconditional, meaning that in a conditional response, the recipients have the obligation to do something in order to receive the assistance. That can be cash, can also be in kind, can be voucher, whatever it is. Typically in a nutrition response, the conditionality would be linked to, for example, the attendance of nutrition education or social behavioral change sessions, or very often also to the attendance of a specific intervention in a health facility, vaccination, treatment, growth monitoring, whatever it is. So people have to do something actively in order to receive the assistance. And that can certainly be a way to incentivize behavior, and for example, when it comes to health-seeking behaviors. Unconditional means that people don't have to do anything specific to receive the assistance. Then we distinguish between, on the level of utilization, between unrestricted and restricted. Basically, unrestricted is usually cash. So if you give cash, people have the choice. There's ways and means you can restrict that, but I'm not going to go into that. Unrestricted is usually in the form of vouchers or also in kind. With in kind, of course, you have the maximum level of restriction. With vouchers, if it's a value voucher, you still have some level of choice. And cash transfers being unrestricted. These in red now, you see the modalities that we have that we saw before in the opening slide. When we talk about vouchers, we talk about commodity vouchers and value vouchers. Commodity vouchers are a fixed quantity of goods and services that you exchange your voucher against, and value vouchers have a monetary value, and you go to a shop and you can use these vouchers as purchasing power to obtain pre-agreed goods and services. Yeah. And then in terms of delivery mechanisms, of course, there's many, especially for cash, but simply speaking, it can be done electronically, for example, mobile money or on a card or a bank account, or it can be cash in hand. We usually call, if you provide it in hand directly, cash in envelopes, or it can be through over-the-counter distributions with a bank, a post office, etc. Yeah. And vouchers, the delivery mechanisms are either electronic vouchers or paper vouchers. Good. Now coming more into the nutrition subject itself. So you can see here a graph from the State of the World Cash Report by Culp, I think it was 2018, where the kind of where practitioners had to rate to what extent cash is being considered in the different sectors. And you can see clearly food security leading the way. I think cash also emerged in that sector, followed by shelter, by wash, and nutrition. We can see that most practitioners at the time didn't feel that it was systematically considered in nutrition programming. Yeah. I think some of the barriers that we have in terms of using cash and voucher assistance in nutrition is certainly a lack of knowledge of cash and vouchers and experience with cash and vouchers in the sector itself. So I think many nutritionists haven't had a lot of exposure, a lot of training in that regards. Also, there has been limited evidence base for kind of the results of using cash and voucher assistance in nutrition in emergency. Evidence base is growing. We'll look at it later, but it's certainly not overwhelming. Yeah. I think the practice has been there for years at a small scale, but from my perspective, I would say that there has been limited learning from practice. Like if I start to dig in, what organizations have done and what they have learned in terms of CVA and nutrition, there's not that much out there. I think also sometimes sector people, including nutritionists, feel that cash is a threat. I think also because sometimes cash people, but also donors, are too pushy and they sell cash as the silver bullet to address, the majority of humanitarian challenges that are out there, which it is clearly not. So I think to have a bit more a nuanced debate on the opportunities and the limitations for each of the sectors, I think is something that has been lacking. And and in terms of results, there's just relatively few practical examples. So this is, from my perspective, some of the barriers that I see. Now, looking at the conceptual framework for malnutrition, you can actually, like if you try to locate cash transfers in here, it actually figures under the basic causes, which is basically income. So cash is, of course, a form of income, at least while you receive it, like in the duration of the intervention. If you're a recipient, it's a form of income. And it's also a financial capital or a financial asset that you can use to transform into other forms of assets, obviously. So cash temporarily addresses the lack of income and the lack of financial capital usually at household level. Now, coming to the underlying and immediate causes of malnutrition, I think we have different pathways that kind of lead to improved nutritional status. One more coming from the food security side, another one coming more from the care and feeding practice side, and one maybe coming more from the water, sanitation, hygiene, and health side. You can see that these arrows have different kind of strength, and the first one certainly is the one where we have the most convincing evidence that at least to address the underlying causes that it works. So cash has, in almost all situations where it's provided in emergency contexts, will improve household food security to a certain degree. Yeah. We know that how dietary diversity, food consumption score are usually improved. The expenditure on food is also improved following a cash distribution. This does not necessarily then translate into household dietary diversity of individual vulnerable household members. Yeah, that's already the first obstacle there. And even if it does, it doesn't necessarily mean that that the nutritional status will be improved, because of course malnutrition is a complex problem and is impacted by many other things. Now, for the impact pathway regarding care and feeding practices, I think there we have rather limited evidence that cash can have an impact. If you think about it, I think it's clear that if
just get educated, we meet each other, provide updates,
hello.
Sharing that needs, coordination happening. But we need to have.
Hello, thank you. Okay. Yeah. So, for example, families that suffer from economic pressure, I think cash can alleviate that to a certain extent. I think it has proven in certain contexts to reduce stress levels, within the household, between the husband and the wife, etc. But of course, in certain instances, we also know that it can potentially increase also tensions within the household. Yeah. It can also free up time in terms of caregiving. If a pregnant or a lactating mother, for example, has the economic pressure to have to work in order to feed her family, I think a cash transfer can alleviate some of that pressure and maybe provide more time to particular individuals to provide better care. But again, there the evidence base is not so strong. Certainly not as strong as for the household food security part. Then on the unhealthy household environment and inadequate health services, I think we can see that cash in some contexts can certainly facilitate access to health services if some of these barriers to health services are economic nature, so having to pay for transportation, compensating for opportunity costs, etc. On the water, sanitation, hygiene part, there is also some evidence, but it's not as strong. So we have varying degrees of evidence for the way that cash can actually impact underlying causes and how these underlying causes translate to improvements at the immediate causes and actually result in improvements of the nutritional status of children. Yeah. Good. Now, looking at some of the demand and supply side barriers to nutrition security, I try to arrange them according to these underlying causes, starting with food security barriers. You can see the supply side barriers on the left and the demand side barriers on the right. And for example, on the supply side, you would have things like nutritious food is not available, the market is physically not accessible, also because of the cost of transportation. You have insufficient awareness regarding the importance and preparation of a nutritious diet. You have inadequate storage and preparation at household level. And you have, of course, the problem that food is not necessarily adequately shared within the household, and it's not shared in a child-centered way. Yeah? And on the supply side, you would have things like food production, importation, availability of nutritious food in the market, questions around quality of the food, food price stability, and again storage, especially of fresh foods. When it comes to care, on the demand side, certainly the inadequate care and feeding practices, lack of time for caretaking, so the economic pressure that some families and caretakers are under, and also inadequate physical and mental well-being of the caretaker. And on the supply side, you would have the services to support that provided to ensure adequate care. So, for example, the instant young child feeding services. Health-related, on the demand side, you have inadequate health-seeking behaviors, the fact that in some contexts maybe malnutrition is not perceived as a disease as maybe other diseases are. Health services are not affordable. Also, for example, if the complicated case and the caretaker has to stay in a health facility, that comes with a cost. It's not only about transportation, which brings me to the next point, which is health services are physically not accessible, which my point here is mainly in regards to the cost of transportation. Yeah. And the wash-related barriers, you have, for example, inadequate hygiene practices, maybe safe water is not affordable, and on the supply side, inadequate availability and quality of water and inadequate water and sanitation infrastructure. I forgot to mention the supply side barriers on related to health. So there will be related to the health services, the availability, the quality, maybe the unavailability of therapeutic or specialized foods, medication, vaccination, and also the disease environment will play there at outbreaks of specific diseases. So these are to look at some of the demand and supply side barriers. And I'm just trying to highlight here some of the things, because cash always works on the demand side. And I'm trying to highlight here some of the barriers that potentially can be addressed with a cash and voucher approach. For example, nutritious food not affordable. Families don't have the money to buy a nutritious diet. And we all know that a nutritious diet is more costly than just a diet that covers your energy needs. Then also anything related to cost of transportation in regards to visiting markets to buy these things, but also in regards later on cost of transport to visit health facilities. Their cash has a role to play. As mentioned before, the lack of time for caretaking, so the economic pressure can be relieved with certainly with cash. I'm putting here a point in blue because there is some evidence out there that cash can actually or like a more stable income can improve the well-being of caretakers, but I think there it's evidence is not as strong, and there's also conflicting evidence out there. That's why it's not as straightforward as maybe the others. Then in terms of health seeking, I think conditional cash can certainly encourage health-seeking behavior. So if people have to do something, visit, do a certain health intervention in order to receive the assistance, that can improve health-seeking behavior, at least temporarily. Health services are not affordable, as I said before, and not accessible. Yeah, and then of course safe water not affordable. Although we all, I think, have to agree that buying bottled water with cash is certainly not a sustainable solution, but in certain situations maybe cash can actually help to temporarily access safe water. Good, so that's some of the economic barriers. So you already see from this picture that there is opportunities for cash, but it's not going to address all the different elements on the demand side, because a lot of it is related to behavior, to practices. Yeah, so the role of social and behavioral change is really big there. And on the supply side, cash cannot really act. So you need supply side interventions and other kinds of interventions to strengthen these kind of services, to strengthen food systems, etc., in order to also complement the cash response. Yeah, because for example, if nutritious food is not available in the market, you can give as much cash as you want. People are not going to be able to buy what they need. Yeah. Now, coming to the different components of cash and vouchers in a nutrition response, and starting off with the household basic needs assistance. Yeah, you can see here 3 symbols. The in-kind component, usually we would refer to the general food distribution. Yeah, so that's usually the kind of in a nutrition response, the household level assistance that we have in many contexts, and certainly was dominant in the past. Nowadays, that component is in many contexts being replaced through a cash response, and often it's a basic needs approach. So in these contexts, we would refer to multi-purpose cash. But you can also imagine to have a cash amount that only reflects food needs. Yeah. But more and more we're moving away from that and looking at basic needs a bit more broadly. And you could have the same, of course, with vouchers. We have to recognize that it's more difficult to address different sectoral needs with a voucher, but it's not impossible, and certainly for food needs, certainly done in many contexts. Now, already here, I think there's a very strong linkage between basic needs assistance, especially on the cash side, and the whole notion of social and behavioral change when it comes to nutrition, a nutritious diet, care practices, IYCF, but also water and sanitation practices, etc. I will look at that a little bit later, but here I introduce the term of nutrition-sensitive cash, and the social and behavioral change is a key component of a cash transfer that is more nutrition-sensitive and is maybe better able to achieve nutrition outcomes than just providing cash alone. Yeah. Then on the prevention side, and just to be clear, so cash plus social and behavioral change can be a preventative strategy, and we'll look at some of the experiences later. But maybe to mention some of the more typical prevention interventions here, we have prevention of micronutrient deficiencies, we have blanket supplementary feeding, and we have other health services, for example, vaccinations, deworming, or pre-postnatal care. The list could be continued, obviously. When it comes to the first two, usually they are provided in kind. Yeah? So micronutrient products that are provided to address certain gaps. Blanket supplementary feeding usually contains a mix of different food items. Here, what we see quite often is, from a voucher side, the fresh food vouchers that try to enable families to have a more diversified diet, especially in combination with, for example, an in-kind ration, but it could also be a cash household level assistance. So the fresh food vouchers to diversify, to give access to animal source products, but also other nutritious foods, vegetables, etc. And cash could also be used potentially there as a top-up to address maybe the specific additional nutrient needs within a household. Now, the health services obviously are, I mean, that's a service that, of course, you can give cash to facilitate access, but the service needs to be there, and usually, in most cases, it is for free. Yeah. Looking at more at the treatment side, where I just here distinguish between the targeted supplementary feeding, the therapeutic care, and the treatment of micronutrient deficiency disease. Now here you can see all these crosses, meaning these are all health services that either are provided by government facilities or kind of, supplemented through humanitarian action. And you can also see the in-kind symbol in all the three treatment options, which are basically the specialized foods and the therapeutic foods that are provided in as part of the health service, as take-home rations, but also as interventions in the health facilities itself. You see that cash doesn't list there because these usually are also products that you don't find on the market, so it's not really an option to provide people money so that they can try to find it somewhere, but it's really something specialized to treat different forms of acute malnutrition. But of course you can then see the symbols below health services, so here again cash can be provided in a more limited form to facilitate access, or maybe to compensate for opportunity costs, or to allow a mother to stay with her sick child in a health facility during the inpatient phase of the treatment. Yeah. So that's a bit the overview on where the opportunities lie in regards to integrating a cash and voucher response into kind of the nutrition response modalities. We'll look at each of these in a bit more detail. First of all, starting off with cash and voucher basic needs assistance, which, as we said, is usually unconditional. So these multi-purpose cash grants, or can also be vouchers, which are typically based on food needs, but you could also add other things into the voucher program. These type of interventions, they can contribute to nutrition outcomes or improve effectiveness of other nutrition-specific interventions for treatment and prevention. So, of course, all these different things can be, all these different elements here, they can be combined depending on the analysis, depending on the situation on the ground. Typically, a household level assistance can really facilitate and improve the effectiveness of the other interventions, or sometimes even, for example, for blanket supplementary feeding is a prerequisite. Yeah. But what we have to state here, and we saw it before also in when we were discussing the frameworks, cash is usually not enough to improve nutrition state. So simply giving a family cash, well, you can get lucky, because maybe in terms of barriers that we saw, maybe the most important ones are the economic ones, and you give a family cash and it can happen that it can improve the nutrition status, but in most cases we know that the problems and the barriers are much broader, much complexer, and cash cannot address the entirety of these barriers, so usually it doesn't as a standalone intervention improve nutrition status. And we have here couple of examples of where cash was provided really at household level with little additional interventions, and one is from Somalia, which is the Refani study, and there, I mean, it was actually cash was there provided in combination with NFIs and piped water, and compared to the outcome of a control group, and there was literally no difference in rates of acute malnutrition. There were some improvements of dietary diversity, including of women, but it didn't translate nutrition status. In Niger, on the other hand, this is a study, and I can include the links in the presentations once I share it, so that you can access that directly. There was actually an impact on anthropometric measurements of children between 6 and 39 months by giving cash alone. Yeah, so like I said, in some contexts it might work, in most it doesn't. So it's cash alone, it should not necessarily be a strategy to try to achieve nutrition outcomes. Now, I mentioned before the notion of or the term nutrition sensitive cash, yeah? And here we talk again mostly about multi-purpose cash grants. And here I list a couple of interventions that can be done to make sure that multi-purpose cash has a bigger nutritional impact, or is more nutrition sensitive. Yeah? And I think that one of the key things is really to try, to the extent possible, to pair it with social behavioral change and nutrition education. I think that's really a good practice, and we'll get back to that in one of the following slides. An additional one is to include nutrition in the targeting criteria, so to really focus on specific groups, on vulnerable groups, and to focus on the first 1,000 days. Then also to really make sure that nutrition is appropriately reflected in the minimum expenditure basket and in the calculation of the amount. And if we can really be confident that an NPC is nutrition sensitive, we should also be able to look at some of the nutrition indicators that go beyond simple food security indicators at household level. For example, the dietary diversity of children within a household, of women within a household, etc. Yeah. One preventative strategy that is often used is really combining the household cash with social behavioral change for nutrition. And here, I think what is important to point out is that cash allows people to act upon what they learn in some of these sessions. So if the education session explains to people that they need to take care or they need to ensure that the household has a nutritious diet, that the children are able to eat different kind of nutritious foods, etc. And the cash allows people to put that into practice by going to the market and buying these diets that are suggested. Yeah. At the same time, social and behavioral change can kind of nudge people towards improved nutrition and child-centered decision making. Yeah. So by explaining to people what they have to take care of when introducing complementary feeding, or when preparing the diet at household level, but also when it comes to wash practices, etc. It can direct how people spend their money in a positive way. So there's the two concepts can mutually reinforce each other, maybe better than other combinations. Now, the cash practitioner, or some of them, would probably say, well, but people always know best what they need, no? And this is probably something that if you are a nutritionist and you've had discussions with some hardcore cash people, that's probably what they might have told you. But we also have to recognize in some sectors that people actually, they don't know best. Neither do I or other people when it comes to, for example, nutrition. So we also have to recognize that that decision making, how money is spent, especially when it comes to nutrition outcomes, people don't always take the right decisions, and there's really a need to invest into knowledge of these concepts. Cash, if provided conditional, can also incentivize participation in these activities. I mentioned that already. Now, how that social and behavioral change looks like, what kind of different elements it covers, and how realistic it is to build it into an emergency response, I think that's a different question that I haven't had enough time to look at, but certainly a challenge. But there is experiences out there that look into that. Considering the time, I'm not going to talk about these different examples that I mentioned here, but I'm very happy to share the presentation with all of you and include the links to the different studies, which all these studies actually look at cash combined with some form of social and behavioral change communication. Yeah. Now, what else? How else can we use cash as a preventative strategy, or as a component of a prevention strategy? So cash can complement preventative in-kind interventions, like we saw before, providing, for example, general food distributions and the fresh food voucher top-up, or a cash top-up for dietary diversity. Can cash voucher assistance replace blanket supplementary feeding or micronutrient deficiency prevention in some contexts? That's actually a question. So can we use cash to replace blanket supplementary feeding or vouchers? I think this is a discussion that has been discussed also at higher level. Don't think that there is a clear consensus on that. From my perspective, I would imagine that under certain circumstances it is possible, but I don't want to lean myself too far out of the window here. Cash and vouchers can remove access barriers to health services. I think that's fairly clear. And conditional cash can provide an incentive to seek health services and participate in activities that we talked about. We need to understand food markets and health systems. I think this is extremely important, of course. So the role of market assessment, but a market assessment that goes beyond what we maybe typically look at. So we really need to make sure that we understand what is available in terms of nutritious foods, and whether these products in the market actually allow people to have a sufficiently balanced diet. There is, for example, the cost of the diet methodology that is out there. It could be a good entry point. And for the health system, there is the HERAMS, which stands for a health resource availability monitoring system. That's more to look at the capacity of the health system. Like I said before, cash addresses only the demand side. You need to understand the supply side in order to make sure that the cash actually can have an impact on nutrition. Because if the services and the goods are not there, there's no point in providing cash and voucher assistance. In terms of objectives, I think it's almost always important to keep in mind what is it that we want to achieve with cash. If it's household cash, it's usually looking at basic needs. It looks at household dietary diversity, food consumption, maybe access to some services, etc. But if it's, for example, a cash top-up or a cash more as a complement to household assistance to address or to be part of a prevention strategy, it might be other things. It might be specifically providing cash to facilitate access, to cover opportunity costs of women spending a day or 2 or 3 in a health facility. But also then really specifically covering locally available fresh and fortified foods and dietary diversity. Yeah. So always important, what is it that we want to achieve with the cash? Because it's such a flexible modality, we need to be clear what is it that we intend to achieve. And here are also a couple of examples. Now on the treatment side, so treatment always involves interaction with the health facility. So cash in itself cannot, replace anything, but it can complement the treatment response. It can also compensate for transport and other costs. And here the objectives, if you complement cash with treatment of moderate or acute malnutrition, it would in the same way look at access, opportunity costs, but then also maybe inpatient costs. And also what we've seen in some studies, if complemented with treatment of SAM, it can, for example, improve recovery, it can reduce relapse, and it can reduce non-response to treatment and some other things. So also there, the cash, it's always important to keep in mind what is it that we want to achieve by giving a certain person or a certain household a certain amount of cash. And if you want to only address access, the amount would be very different than if you want to address household food security with a cash approach, obviously. Now here with treatment, we have the challenge of targeting, because targeting based on nutritional status can lead to perverse incentives. For example, if people know that they will get a certain level of cash payment if they bring their SAM child to a treatment center, they might be incentivized to keep one of their children undernourished. And there's very little documented evidence for that, but there's a lot of nutritionists that say, well, we know that this is happening. Which I don't doubt. The question is always to what extent it happens, and what we can do to mitigate some of these risks, because there is strategies that you can apply. One study that looks at combining treatment of SAM and cash is actually from the DRC, and there the results were very positive, but also in a very controlled environment. Some additional considerations. I know I'm already taking more time than I had intended. Conditionality is quite important. I think there's some evidence that points in the direction that conditionality can actually be conducive, especially for health seeking, maybe also for attendance, but it of course always comes at the cost. Yeah? And there's a debate around whether we should impose soft conditionality, which we communicate, but we don't enforce as rigorously as the hard conditionality. Hard conditionality means if you don't do that, you're out of the program. Yeah. Then the amount, and we haven't talked about that. The size matters when it comes to cash and nutrition. We from different studies, we know that the more you give, the better results you have, and that's not necessarily a surprise, but it's important because we tend to give very little and then be kind of surprised that the nutritional status of children hasn't changed. Because cash can address different underlying causes, we also need to make sure that the amount actually reflects that, and that the amount that we give for nutrition or for nutritious food is actually matches a nutritious diet, and it's not just a translation of an in-kind basket that we would usually distribute in physically. The positive effect on cash does not often extend beyond the intervention. So while people receive cash, it can have a positive impact. But once you stop the program, they will go back to not receiving anything. So we have to think also about more sustainable solutions in relation, for example, to livelihoods or social protection. Who receives the transfer matters. Very simply spoken, give it to the women. Cost efficiency and cost effectiveness considerations are relevant because cash is such a flexible tool that if it's unlikely to be cost effective from a strictly nutritional perspective, I would claim, but this is something that we'll have to look at more closely. Linkages to social protection and the role, of course, of supply side interventions. Very briefly on the GNC's involvement. So the review of evidence and practice is ongoing, and I've been talking to quite a lot. If your mic is on, please switch it off. Thank you. I've been talking to quite a lot of key informants, and if you haven't been interviewed and you feel you have something to share, please let me know. We have a reference group in place that contains about 20 people that support the work, my work, and the work of the GNC. And some of the next steps are to finalize the outline of the guidance, start the drafting. There will be up to 3 case study documentations, which will happen in Q1 of next year. Then the guidance note should be finalized somewhere around May, June of next year. I will have some potential capacity to provide technical support if I can fit it in. And I think once the guidance is there, it would be great to work on a capacity building strategy for the GNC, but also for maybe partner organizations. In order to make nutritionists more comfortable with CVA, and in order to explain like I said, the opportunities and limitations. Just to speak very briefly about one of my biggest challenges, which is I lack examples of nutrition projects with a cash and voucher component. I have here a screenshot of the interventions that I have identified through conversations. I lack documentations of most of them. So if you and your organization has interesting projects that are ongoing, that are documented, please share so that we can start to have a common understanding of ongoing practice and of lessons learned. Yeah. And some key resources. If you're interested to learn more about this topic, this would be the starting point. So look at the Innocenti paper from 2015, at the Rafani Literature Review and Synthesis report, at R4ACT final report, and at ODI, What Does the Evidence Say?, which has a section on nutrition. And that is it. And I took too long. I'm really sorry. But I'm going to see whether there's any questions, and I will want to open up the floor to questions that you might have now. Please go ahead. Don't be shy.
Andre, this is Yara.
Hi,
I just
Yara.
want to say that, hi. I just want to say that you have a few questions already in the box, so maybe if people don't want to speak.
Okay, so I'm gonna read them. One is from Wilfred. In emergency context, the market is likely not functional, so the use of cash could be a major setback in addressing nutrition needs. I think that's not a question, that is a statement. Okay, that is certainly true. Then from Mia. Nice to see you, Mia. You state that cash is usually not enough to improve nutrition status. Do you mean cash or CVA? Um, well, probably both. But certainly, I mean, the voucher is in some contexts an interesting modality, but I think cash will be the predominant modality within CVA. I think the better you can combine different modalities, the more you increase your chance. But I think this is really more related to cash is usually not enough to improve nutritional status. But also with nutrition, I mean, with the voucher approach, you could potentially improve household food security and dietary diversity, but that doesn't mean that it will translate in a nutrition status, at least from my perspective. Okay. And then do we have any actual documentation on perverse incentive? We seem to always be worried about them, but it would be great to see some actual data. This is from Alison. Yes, so if anybody has, please come forward. I've asked this question multiple times to people that have flagged it, and it doesn't seem to be something that we document. Yeah, so if you have anything, it would be great to see that. For me, the main question is really, what is the extent of the problem? Because if it happens among 100 cases one time, that is a different type of problem than if it happens among 100 cases 30 times. So it of course, it might be very context specific. So I think this is definitely something that we need to better look at. I know the ICRC was planning a research on this in Somalia, but it had to cancel it because of the security situation. And then I have a question from Brian. You mentioned the importance of including nutrition in the MEB calculation. What is your sense in how commonly nutrition is considered as part of these calculations? So, I mean, food security is always the most important component of an MEB. But the question is whether the food whether the food products that are placed in the MEB do actually reflect a nutritious diet. I think that is the main question. Often what we see is that in some contexts that is just a translation of the in-kind ration, which is which is just not sufficient from a nutrition perspective. And then sometimes we also see that the MEB is really stripped to the minimum, so you wouldn't necessarily include a lot of fresh products and vegetables. But I haven't done yet a broader scoping of how exactly it is included in different minimum expenditure baskets. So this is definitely something that we could be looking at in more detail. Then I have a question from Chabuli. Is there any documented research exploring why cash does not necessarily lead to improved nutritional status? Yeah, I mean, all the different research pieces that conclude that there was no impact, and there is a few, they look at possible explanations, and often what they find is, because in most of the research pieces, cash is given with a food security logic. Yeah. So they in the discussion, it often mentions, yes, we were able to improve household food security. First of all, it didn't translate into dietary diversity of vulnerable groups among the household. And second of all, if it did, maybe there was other factors that kind of negated that positive impact. Maybe there was seasonality that came into play, or disease outbreaks that led to no change in the nutritional status and in the prevalence of acute malnutrition. So there is different papers that look at that, but to find a conclusive answer is probably quite difficult. So again, like with any kind of nutrition intervention, you need to think about all the different aspects and come up with an integrated approach where cash can play a role, doesn't have to, but as we discussed, there is certainly some things that cash can do. And then there's from Eric a question. It's more. Okay, I'm just going to read it. I thought that the R4 Act full report was useful and informative as a state of evidence, but the one-page executive summary, which obviously gets more circulation and enjoys more influence, I thought overstated some of the elements, particularly in terms of characterizing the strength of evidence, perhaps more positively than the full report. Did you and others in this community have a similar reaction to this? I bring it up as the work is important, but the dissemination is really important, obviously, as well. Yeah, it didn't strike me, and I'm not sure what others think. I'm running a bit out of time, so I think I have a individual call with Eric scheduled, so I'll take up this with him at a later stage. And here are more questions coming in from Mia again. Hi, Andre, can you share with us your email so that we can send examples, good, bad practice? Yes, absolutely. And I'm going to go back to the first slide. My email is andur@unicef.org. I also launched an appeal on, or a question on the CalpD group a while ago. Got some reaction there, but anything you could share, Mia and others, would be wonderful. And then we have Rosalind. When you talk of impact on nutritional status, do you mean impact on anthropometry or other nutrition markers? Inevitably, given the multifactorial causality, direct attribution to cash assistance will be questionable. Yeah, I know that there might not be a common understanding on nutrition status. So yes, when I talk about nutrition status, what I refer to is anthropometry. When I talk about nutrition outcomes, at least in my mind, I also think about, for example, indicators of for example, dietary diversity and other food security related indicators at individual level. Yeah. So projects, for example, that try to improve dietary diversity of children under 5 or under 2, I would consider them as interventions with a nutrition outcome in mind, while projects that look at household dietary diversity, household food security related indicators would more, for me, be in the nutrition security sphere. But I'm happy to be challenged on that. But at least that is how it has kind of made sense to me. Good. Any other questions, comments? Okay, great. So I hope this was useful. It was certainly useful for me to put this together because it always is good if you're forced to explain something. Yeah, it has to first make sense to you, and also forced to visualize things. I think it's often important. I hope it made sense to you. I hope you saw some of the entry points. I think there's nothing particularly new in there, but I think it will be really important to put this into a guidance as best as we can. I know there's still a lot to learn, but we have to start somewhere, and just saying the evidence base is not strong enough so we cannot do it is just not good enough anymore, I think, when it comes to cash and vouchers in nutrition. So we know already quite a lot of things, and it's really now up to us and up to me to put that into a good document and to provide the necessary guidance for nutrition practitioners and our nutrition cluster coordinators in the field to make it happen. So thank you very much. As I said, this was recorded, and I will share the link with you. And on Thursday, there will be the same session in French. So if you have anybody that speaks French and that might be interested, feel free to spread the word. Thank you very much, and have a good day.
Thank you.